As I said earlier, today we will discuss about hairy cell leukemia. Very important topic. Whatever I am discussing in this lecture, every line has been an exam and is an MCQ. The hairy cell leukemia is an B cell lymphoma. Okay, it is of a B cell origin, and this epidemiology is very minimal, like 2% only it occurs, and the median age group is between 50 years, and in a variant cases it can occur in older age groups. So moving on to the most common gender, it is more common in men. The ratio is male to female ratio is 4:1. The reason is not known. Next important point is there is two types. One is the classical hairy cell leukemia, and other is the variant hairy cell leukemia. So in classical hairy cell leukemia, the mutation is your BRAFV600E, whereas in your classical variant it is IG hemoglobin heavy chain 434, and most importantly the BRAFV600E mutation follows the classical pattern, whereas the IgG hemoglobin heavy chain is your mature B cell. So it follows an variant pattern and it activates MAP kinase pathway. So the other important clinical feature is that it is like a single most important finding I find in a patient is splenomegaly. It's a very important finding, and it may be the only finding that you could see in the patient or elicit in your patient. The other findings would be attributed to your anemia or pancytopenia and bone marrow infiltration. Symptoms relating to your anemia, pancytopenia, and other important thing I want to discuss here is that your diagnosis. So for diagnosis, earlier there was a role for something called as TRAP positive, that is tartrate resistant acid phosphate positive, but after the introduction of flow cytometry, this test has become of a less importance. So in flow cytometry, what you look for, mainly we look for annexin A1 very much positive, and your CD23, CD103. And one more important point here I want to tell is that it is positive for your cyclin D1. One more important lymphoma that is positive for cyclin D is your mantle cell lymphoma. But here there is no translocation of 1114. Okay. And other important finding here is that the bone marrow biopsy is usually a dry tap, and there is a appearance called as fried egg appearance. This has been put in your shorts. but it's due to your abundant cytoplasm. The pictures I will show you. And the peripheral blood smear picture shows hairy cells. These hairy cells are due to your P-actin or the that polymerases to F-actin that gives the projections. Actually, these bind to your phosphoprotein PP52. These are the leukocyte specific phosphoproteins that acts as a receptor for your F-actin, so they give you the appearance of an hairy cell. So these are the hairy cells that is due to your P-actin that polymerases to F-actin, and it sticks on your receptor called as the phosphoprotein PP52, and the bone marrow biopsy gives you the fried egg appearance. And one more advancement you can say is that there is also FLT3 upregulation in some variants of your hairy cell leukemia. Okay, this FLT3 upregulation is an important landmark in your recent advance. Okay, so some of the drugs targeting these FLT3 mutations play a vital role in the treatment of your hairy cell leukemia. So moving on to the treatment of your hairy cell leukemia, earlier there used to be a surgical management because of a splenomegaly, so they used to do splenectomy, but splenectomy was effective treatment and it has been remained as the therapeutic modality of choice for many years, but due to the mechanism of benefit is not clear, removing the spleen leads to normalization of your peripheral smear, and it accounts in approximately 1/2 of the patients, nearly 50% of the patients get normalized peripheral smear after splenectomy. But later, with the introduction of your purine analogs and interferons, the treatment of modality changed. So the drugs in the interferon is your interferon alpha, and the purine analogs what you use is your pentostatin, and one more drug is cladribine. So pentostatin, all these drugs what they do is that they bind to ADA enzymes irreversibly, and ADA is one of the important enzyme that is called as adenosine deaminase. Here there is one more important question that has been asked previously, is that deficiency of adenosine deaminase leads to SCID, severe combined immunodeficiency disorder, because what happens, even if you give these drugs, it blocks your ADA irreversibly, so that the patient's leukocyte or the lymphocyte counts deplete very rapidly, so the patient becomes very much immunodeficient. So one other important drug or the very important discovery or the milestone in the treatment of hairy cell leukemia is your rituximab. So knocks your CD20. So rituximab has been given for your in 2 doses. Hairy cell leukemia dose. One is 375 milligram per dose per week for 4 doses, or 375 milligram per dose per week for 8 doses. So with this, the overall response rate is achievable. So the problem is, whenever there is a variant of the hairy cell leukemia, the treatment is that they are resistant to this rituximab. So already I have told two mutations that are causing the variants of hairy cell leukemia. One is your immunoglobulin heavy chain 434 and your FLT3. So all the best for your exams. Please read about this topic. It is a very important topic that has been repeated again and again in your exams.